This lesson will review documentation and some other miscellaneous topics for extended hour nursing. The objectives for this component are to be able to verbalize parts of an MD order and correct communication to the clinical manager for updates to the patient's plan of care, identify documentation and reporting expectations, including components of the client's plan of care and the patient chart, and to review documentation including completion of a nursing note and an incident report. The clinical manager at each case should be considered your supervisor. The clinical manager's role is to manage the case by coordinating and collaborating patient care. A big component of a clinical manager's role is to assess the patient and complete an assessment to submit to the payer source. So each of our clinical managers is trained in a standardized assessment tool to determine how many hours of nursing a patient qualifies for. The nurse's assessment is just one component of the amount of hours that a patient receives. The other components include the physician's order and the payer source authorization. So there are times when a clinical manager may complete an assessment and recommend perhaps 16 hours of nursing for a patient. A physician agrees and says 16 hours sounds appropriate, and then a payer source may come back and say, we'll actually approve 12 hours. So there's a lot of different pieces that go into that, and you're always welcome to ask your clinical manager if you have questions about the amount of hours that your patient receives, and your clinical manager can explain the assessment process. The clinical manager writes the plan of care for the nurses and/or PCAs to follow and visits the home routinely. For extended hour nursing patients, that's every 60 days. You may or may not see the clinical manager when he or she comes out every 60 days, but they are doing a visit at those times and will review documentation from the home on a regular basis. Clinical manager also should be a resource for you for problem solving. Report yourself your own infections and patient infections or hospitalizations. You'll also be asked to complete weekly or biweekly updates depending upon the patient for the patient's plan of care, and we'll review that later. Call your clinical manager with any issues or concerns. So frequently we have classes where we discuss our questions that we have, and different people bring up different examples at different homes. And so often the answer is speak with your clinical manager. Your clinical manager should get to know the ins and outs of the home and the patient and the family and be able to really work as a liaison between the patient and the family and the staff in the home. Also report any diversions from the care plan. So if the care plan that's in the home has any outdated information or incorrect information, please let us know that. We respect that the individuals in the field are the ones who are really knowledgeable about the patient's cares. Accurate is moving forward on an electronic medical record. We are partnering with CanTime, and we will be in touch as more information is available and field staff implementation begins. But at this time, we are completing paper documentation in the field. So documentation guidelines include the fact that you must complete your documentation by the end of your shift. There should be no catch-up documentation, and likewise there should be no going back and completing documentation or going ahead and completing documentation. Entries into the clinical record must be made by the individual providing services, so you have to complete your own documentation and you must sign and date your documentation. It should include data regarding assessment and observation, as well as education provided to the patient and family. That's so important that as nurses, we're often providing education without realizing that we're doing it. And so it's incredibly important to make sure that you're documenting that information. That's a major reason for patients to have nursing in the home is education and assessment of the patient. So your documentation should reflect that. We do have payer sources routinely request copies of clinical documentation, and so it's expected that it will reflect all of the services that we're providing, which includes education. If you need to correct your documentation, ensure that it does not obliterate the original entry. So typically drawing one line through the error and marking as an error and labeling with your initials, that will work just fine, but you don't ever want to be scribbling things out or using whiteout. So again, if you make a mistake, just draw one line through it. Also, if you forget any documentation and you make a late entry for some reason, ensure that you're labeling that as a late entry. So if for some reason you come onto your shift and the individual before you forgot to write a nursing note, don't leave a blank space for them to fill in their nursing note. You go ahead and use the next line, and the person who forgot then will need to note late entry for their documentation. So we're going to review the components of a patient chart. When you are in the office for your skills checkoff, you can go ahead and take a look at an example of a patient chart if you prefer to review a hard copy. It's helpful because all of our patient charts are laid out in the same manner, but we're going to go ahead and review the components of the patient chart in this presentation. So the first section, it's arranged into 5 sections. The first section is the client information section, and so we're going to go into explanation of each of these components. Front page of the chart should be this client profile sheet. This is an important place for you to be able to find your patient's contact information. If you ever had to call 911, it's not expected that you'd be able to recite the patient's address, so you can just open up the chart and find this piece right on the top. It has your patient's address, birth date, pertinent allergies, where to find their DNR or DNI information, as well as contact information for your clinical manager. When your clinical manager completes a supervisory visit, that may be a question that's asked. Do you know how to get in touch with me if you need to? So this is where your clinical manager's information is. And in this example, the clinical manager would be Susie, caregiver, and her phone number is listed there. The next page will be a regional team face sheet. So some pictures of the individuals that work in your region. Kind of nice to put a face with a name. Also keep in mind that with this entire patient chart, it really as much belongs to the patient and family as it does to the nurses. Ultimately, it is the property of Accurate Home Care, but the patients have a right to the information. And so at any time if there are questions, please be a liaison or be able to explain the information to the patient and the family. The next document in the chart is house rules. House rules are established for each home, initially upon the implementation of services in the home. And it's something that the clinical manager reviews with the family to just set up some basic guidelines for how this home functions. Things like where you should park, where you should put your belongings, helping to deal with siblings if they're in the home, things like that. You'll also notice the top line here under regarding the home says, smoking in the home is never permitted by Accurate Home Care staff while on duty. Just remember that even if your patient smokes, there's no smoking allowed while you're on shift with Accurate. The meet and greet process is something unique to Accurate that we're very proud of. It's something that our patients and our caregivers alike really enjoy. So there's a little information in the patient chart about the meet and greet process, including some sample questions and guidelines. For you, it's important to know meet and greets last about 15 minutes to 30 minutes, and it's an opportunity for you to drive to the home. Make sure that you can find the home, make sure that you feel comfortable in the neighborhood, see the environment that you'll be working in, meet the patient, and meet the family. Have a surface level discussion about the cares that you'll be providing, and just make sure that you have that general sense of feeling comfortable with the person. Likewise, the patient has the opportunity to make sure that they feel comfortable with you. At the end of the meet and greet, you say it's nice to meet you, and we'll be in touch, and you go ahead and leave the home. You want to follow up with your staffer, and the patient will do the same. So behind the scenes, as you talk with the staffer, you let the staffer know, thumbs up, or maybe not the best environment for me to work in. And the patient will do the same. And if it's a mutual match, then you'll proceed with being placed onto the schedule. The next document is an extremely important document for you to review in the home. If I could tell you your top 3 documents to take a look at, it would be this, the nursing plan of care, as well as the 485, which we'll come to next, and the house rules. Definitely your top 3 that you want to look at when you're new to working with a patient. So the nursing plan of care explains in detail the exact cares that you will be providing for this patient while you're in the home. Nursing plan of care is generally good for 1 year, and there are certainly updates that are made to it from time to time as needed. So a lot of demographic information on this first page, the DME or Durable Medical Equipment Company, what equipment the patient has in the home, code status, allergies, diagnoses, surgical history, how many hours of nursing the patient has. And then next is the emergency action plan. Every patient has an emergency action plan noted in 2 places. One is the nursing care plan, as you're seeing here. The other is on the 485. You need to review this emergency action plan for each patient that you work with because it contains some patient-specific information. So it's important to know exactly what would you do if there was a fire, or what would you do if there was a tornado? Where's a place to take cover in this home? How do I get my patient out? So for example, maybe your patient is wheelchair bound and lives in a 3rd floor apartment. Well, what's your plan going to be if there's a fire? Because you're not going to be able to take the elevator, and you're not going to push the wheelchair down the stairs. So again, think through those things and ask yourself, what if? And a big part of that is reading through the emergency action plan and knowing the steps that you're going to take in an emergency. After that, it reviews current medical status, just a quick summary of this patient, and then it goes into the cares, pretty much starting from the head to the toe, and reviews what you're going to do from a nursing perspective for this patient. So this example, this patient has a trach, so you're going to learn about the emergency airway clearance protocol, respiratory information, ventilator settings, skin, musculoskeletal, immunologic system, GI, nutrition, important to know what your patient is taking in for nutrition, bowel program considerations, neurological information. So again, going through all the different body systems. Also take a note that this one says restraint use is not approved for client. Very important for you to know your patient's restraint status, and we'll discuss documentation of restraint use later. Pain, client and family teaching needs, all this information is available here, as well as the vulnerability assessment. This is a required element that we assess this patient's vulnerability on a number of different items. If the patient is determined to be vulnerable, then there's a plan here to prevent any adverse effects from that vulnerability. This document is called the 485. I know the title says Home Health Certification and Plan of Care, but way down here in the corner it says Form HCFA 485. So it's important to note this is your actual signed physician order for the cares that you'll be providing in the home. So this is kind of arranged like a tax document in that each box is numbered. This is the front page on this particular example. So the patient's name is here, Tracy Training. Other sections on this front page to note: certification period. 485s are good for 60 days. This is the reason or what spurs a clinical manager's visit. So a clinical manager is required to visit the home between day 56 and 60 of the certification period. So you'll be looking for the clinical manager at that time, and it would be a great idea to write any updates directly onto this document. This next box over here, box 10, medications for the patient. They may be listed here or they may be listed on a separate document depending upon how long the patient's medication list is. Box 14, durable medical equipment and supplies. Anything that doesn't fit on this first page will be continued on a subsequent page. So box number 14 is DME and supplies, and we'll come back to that. Box 15, safety measures. So it says right here, full code, reviewed at client visit. So you need to know your patient's code status for any patient that you work with. Realize that code status can change, but code status is not just a conversation, it is a physician's order. So you always need to go by the current 485 and the signed order for the patient's code status. This next box down here, 21, orders for discipline and treatments. This is really kind of the meat and potatoes of your 485. It's also almost an exact copy of the information that's in the nursing care plan. It's just a little bit of a different layout. So again, anything that doesn't fit on this first page is going to be continued on the second page. So we talked about that box 14 with DME and supplies. That list is continued right here. And box 15, safety information. So this is that emergency action plan, the second place where we talked about seeing the emergency action plan. Box 16 was nutrition on the front, so it's continued in this paragraph here. And 21 was that orders for care and treatment, and that was continued in box 21. So it's this whole section here. If we go to the next page, continued again on this page. And this is the final page of the 485. This continues that section 21, including a 60-day summary. So in particular, what's been going on these last 60 days. So there's a summary of that there in terms of hospitalizations, illness, medication changes, things like that. So that's the 485. That again is a document that changes every 60 days. We're required to keep the current copy in the home. Note that there may be a lag time. So if you're just a week or two after the 485, the last certification period has ended. So in this example, it looks like it's dated May 30th of 2015. So if I were more than a couple of weeks past May 30th, I'd want to give a call to my clinical manager and just touch base to see when the new 485 will be received in the home. The next document in the chart is the time card. The time card is shared among all employees in the home in the given service line. So if it's the nursing time card, then all the nurses will use it. There's a separate time card for PCA services. On the top of this document, you'll find the patient's name. So here it says Tracy Training, and then the time card is written for 1 week at a time. So you'll find the day of your shift and the approximate time of the starting of your shift. You'll see that there are spaces here to indicate day shift, afternoon, and overnight shift. It doesn't have to fall exactly into those parameters of 7 a.m. to 3 p.m., but somewhere in there. So you'll write your time in on this line. So if I were working on Monday at 7 a.m., I would write 7 a.m. here. On the next line, I would write my time out, maybe 3 p.m., so I could write 3 p.m. here. In this box, I'll write how many hours that is, so 8 hours, and in this box is my initials. On the bottom, I'll sign and print my name. I'll write my initials and print my name, and then circle my position, RN or LPN. At the end of the week, so after my last shift in the home, or certainly by the end of the day Saturday, I need to total my hours for the week, separating out day-evening hours versus overnight hours versus holiday hours, and then date the last shift of the week. It is the responsibility of the last person who works in the home on the week, whether that's usually on Sunday sometime during the day, or at the end of the shift on Saturday. The person who works last and the time card gets filled up needs to take the time card to the responsible party and ask for a signature. So on the bottom of the time card, it says here responsible party signature, responsible party name. Tracy Training in this example is her own responsible party, so she would need to sign on the line and then date. Her signature indicates that everyone was there when they said that they were there, that everyone worked shifts as noted. We document our shifts in 15-minute increments. So if your shift starts at 3 o'clock and you arrive at 3 o'clock, you write 3 o'clock. If your shift starts at 3 o'clock and you call to let us know that you're running late and you arrive around 3:10, then you would round to the next quarter hour and document that you arrived at 3:15. Likewise, the shift before you then would end at 3:15 instead of 3 o'clock. You may not overlap shifts without prior approval. Also, the patient shouldn't have any gap in coverage unless that's written into their schedule. So if there's any questions on the documentation, please reach out to your clinical manager or speak with the other individuals in your home. But again, it's important to note that this has to always be a current and accurate reflection of the hours that are worked in the home. So once it is signed by the responsible party, then that individual will take the paper and put it into an envelope and drop it in the mail. It needs to be in the mail by Monday at the latest so that it arrives in the office on Wednesday. If the last shift in the home is on a Thursday or a Friday, it's okay to mail the time card at that time. However, if you arrive to your shift on Tuesday, for example, and the time card hasn't been sent, pick up the phone and give a call to Accurate and let us know that you arrived to the home and found the time card still there and that you'll be sending it in, and we can go ahead and get the payroll entered at that time. So again, if there are any questions, please reach out to your clinical manager, but typically having everyone share the time card works out well because everyone wants to get paid. The next section in the patient chart is for observation and assessment. We'll go over these documents. The first document is the health status record. So this actually begins your nursing documentation section of the chart. The health status record is a document that keeps track of your head-to-toe assessments of the patient. So in each column, this represents one head-to-toe assessment. We recognize that you might not exactly go from head to toe during that assessment, so there is an option to complete assessments at different times by body system. So for example, perhaps when you arrive to the home, your patient is in bed and so you can't complete maybe the skin assessment because they're sleeping. So you might do that at a later time of the day. Likewise, you might have to do multiple respiratory assessments during one shift if your patient is having a change. So each assessment would go into one column, and you would write the date and time of your assessment and your initials here in this line. With all documentation, you're going to complete your initials and your signature at the bottom of the page. The nice thing about the health status record is that assessment after assessment will go in each column, so you'll have multiple days at a time on one record to be able to look at. These documents are double-sided, and you'll see several of them in successive pages in the book, and so you'll be able to review the documentation for shifts prior to yours. At the end of the month, you take out all of the health status records for the entire month and start over. So you should never have 2 months of charting on the same document. This abbreviation list over here on the side, this is just a portion of the list or a snapshot of it. There's a longer list in the chart. So these shortened abbreviations will be used to document the assessment because obviously the boxes are pretty small. So you'll use that abbreviation list as a reference when you're completing the health status record. The next document is a nursing note. So you need to complete a nursing note for each shift. Your note needs to include, at minimum, who you received report from, and in what condition you found the patient. At the end of your note, you should also indicate the patient's condition and who assumed cares. So something like arrived to home, received report from night nurse, assumed care of stable patient, asleep in bed. You would document throughout your shift, and at the end of the shift, you could indicate report given to overnight nurse, patient left in stable condition, perhaps in wheelchair in living room or something like that. During your shift, you want to include any abnormal findings or pertinent observations, so especially those that are not included in other documentation. As a rule, we chart by exception, and a narrative note is perfectly acceptable. You may also choose to do a focus note or a DAR note, data, action, response. Those are some other acceptable formats, but again, a narrative note is perfectly reasonable. The health status record, so the previous document of your head-to-toe assessment, and the nursing notes should contain the majority of your shift summary. So when we get requests for documentation from payer sources, those are typically the two documents that we will send to indicate the patient condition and the nursing functions throughout the shift. Care coordination should be a part of your nursing note as well. Everyone who works with a patient is responsible for coordinating care effectively to support the objectives noted in the patient's plan of care. So coordination of care includes making phone calls on behalf of the patient to schedule physician appointments, calling to get orders, speaking with therapists, county workers, even office staff or the patient or the responsible party. All of those things that you're doing, that legwork for the patient, help the case come together and are called care coordination. They should be documented. You need credit for doing that. Again, as nurses, sometimes we do things without thinking about why we do them or the big picture. It's just what we do. But you need to document that because it is just what we do, but we need to be able to support our reimbursement as well. Care coordination starts at initial intake and continues all the way through discharge. The next document in the chart is the vital record. Pretty self-explanatory. Each row would be one set of vital signs. You may use multiple rows throughout your shift, depending upon how frequently your patient is ordered to have vitals taken. You'll sign the bottom, and once again, this document is going to be used throughout the month. You might have multiple pages, and then a new document will be started on the first of the next month. The nutrition record, should it be filled out, this top box here to indicate your patient's nutritional requirements, feeding schedule, recipe of formula, or their diet. Obviously, these will be patient-specific. If there's ever a section on these documents that doesn't apply to your patient, just don't use it. So you would indicate one row here for each feeding. It's important to calculate the amount of feeding that your patient receives during the shift if they're having like formula or a G-tube feeding running. So you can document all of that here. Again, this may be modified to be patient-specific as well. The respiratory support document is something that you'll review with the ventilator class as well, but respiratory support is a record of your patient's respiratory support. So if they have a ventilator, then those settings would go in here. If they have a trach, you would put that information in there, including a cough and things like that. So reassessing as frequently as is ordered for your patient. Sometimes this is every 4 hours. Sometimes this is once a shift. Depends upon the respiratory support that your patient requires. Also important to note here over on the right side, breath rate, PIP, oxygen, and saturation. At minimum, these readings should be changing. You're not just reading them off a machine, but you're rather taking a look at your patient and thinking about what that means for your patient. So breath rate, even though the ventilator is set at 12, perhaps your patient is breathing over the vent. And so right now their rate is 14, or right now their rate is 20. PIP, peak inspiratory pressure, as you'll learn about in vent class, is a dynamic reading, and that can change over time, indicates your patient's lung compliance. Oxygen delivered may change, and saturation may change as well. The next document is a skin assessment sheet. You may or may not see this if it doesn't apply to your patient, but if your patient ever has any sort of wounds, it would be documented on this sheet and documented as frequently as needed or as often as you're reassessing that wound. Seizure record, again, patient specific. If your patient has seizures, then the seizure record will be in the chart. Each column is one seizure, and so you'll indicate what you see during that seizure, the start time, the end time, any interventions that you're performing. There's other documentation in the chart as well, which is patient specific. So if your patient needs an infusion record, a bowel movement log, an intake and output record, or a restraint use record, those will be in the chart as well and are usually pretty self-explanatory, but certainly something that you'll review in your patient-specific orientation in the home. Restraint use is very rare and it requires specific training. You need to be trained to use restraints for each specific client. The use of restraints requires very particular physician order parameters, including the type of restraint, the reason for the use of the restraints, frequency of use, and length of use. It's also critical to remember that you should always try something else before you utilize restraints. So what other procedures can you perform with a client to use restraints as a last resort? The training and competency testing is performed by an appropriately trained nurse or social worker. So it is acceptable, nurses to train each other. Follow your clinical manager's direction for this. The next section in the chart is the medication section, so we'll review these documents now. The physician's order protocol states that physician's orders need to be used when there's any new or changed prescription, therapy, or treatment. You also use the form to record verbal orders. You must include over-the-counter medications. We're not able to give any medications to our patients without physician's orders. Also make sure that you bring some with you to physician's appointments. It's nice to be able to write out the form and be able to get it signed by the physician right at that time. We use physician's order forms to ensure that we have legal orders to provide all of the interventions for our patients. So make sure that you complete all of the areas noted on the physician order form. You are the representative, so you'll sign in that place. And these forms are in the chart in two parts. They're a two-part carbon copy form. The top part is the white copy, the bottom part is the yellow copy. The white copy you'll tear off and mail into the office. Each patient chart has a stack of self-addressed stamped envelopes that you would use for the time card and physician's orders and incident reports. We'll talk about that as well. So you'll keep the yellow copy in the chart and you'll mail the white copy to the office. You can immediately institute that physician's order. Once the white copy is received, we'll send it to the physician for a signature. So there's an example here of a completed order. You can see all of the appropriate sections are filled in, and the medication is filled in as well. You can write the medication in the lines up here under the physician's order, or you can also write it in the box and fill in the blanks. This way you make sure you're not missing any of the information that you need. So this order is for Lasix or furosemide. That medication is a loop diuretic. The dosage is 15 milligrams. Frequency is once daily, and this is going to be a maintenance medication. The route is by G-tube. This patient is receiving it because of congestive heart failure, and it should be given with food. I have the start date of the medication there, and there's no end date because this is an ongoing medication. You want to make sure that you're avoiding any error-prone abbreviations, symbols, or dose designations. This piece of paper is in the chart as well. But also, Accurate does not have a list of approved abbreviations, but we do have unacceptable abbreviations. Those include QD or QOD, BID, TID, QID, CC. None of those abbreviations are approved, so you want to write out once daily, twice daily, 3 times daily. And CCs should be indicated as mLs or milliliters. Then all medications will be placed onto the medication administration flow sheet. So the MAR. You'll see the medications listed here. There's another copy for PRN medications. You'll initial in the box to indicate that you gave a medication. If you didn't give a medication for some reason, you would circle your initials, and your nursing note should indicate why that wasn't given. Likewise, during your shift, if family administers any medication, you'll just mark an F in that box. You don't want to initial that you gave the medication, but it should still be recorded that it was given. Family is always able to administer any medications that are needed for the patient. And anytime you give a PRN medication, you'll document on the PRN medication response record what you gave and why you gave it. And then there should be follow-up to ensure that the medication did what it was supposed to be doing. When you receive a physician's order, you must clarify the medication name, dose, route, frequency, and reason. You shouldn't document giving any medications per family. All medications require clear orders. If a patient is receiving a medication for the first time, so it's the first dose of a medication, you have to document the fact that it's a first dose and monitor the patient for 1 hour afterward, then documenting a set of vital signs and the patient's condition after that hour of the first dose of the medication. Only physicians can write our patients' orders. We can't take orders from physician assistants or nurse practitioners according to our accreditation. So if Nancy Nurse received a new order for a decreased dose of Lasix, and she wrote the order, as we reviewed before, what should she do next? She should update the medication administration flow sheet. So if we have the old order here of Lasix, 20 milligrams by G-tube daily, give with food for congestive heart failure, I would cross out and indicate that a dose change was received and write the date of the receipt of that change, and then I would highlight the remainder of the month so that that medication is no longer given. Then on a new blank copy of the medication administration flow sheet, or in the next open space, I would rewrite the new medication. Lasix, furosemide, 15 milligrams daily via G-tube for congestive heart failure. Give with food, class is loop diuretic. And this medication is going to be given at 8 a.m. I'm going to draw a line through the first 3 days of the month because I received that order on that date, and the next dose is going to be given on the 4th. So everyone that's in the home knows that I'm no longer giving the old dose, and now I'm giving the new dose. So you receive an order, or you are told an order, for Keppra 100 milligrams per milliliter. Give 7.5 milliliters BID. How do you think this order should read? That leaves a lot of room for error. So we should be documenting Keppra, or levetiracetam, that's the generic name, give 750 milligrams, not milliliters, via G-tube, the route was missing, twice daily with food for seizure control. So it's your responsibility to clarify the order, report the new medication to the clinical manager, mail in the white copy of the physician's order to the office right away the same day, add the medication to the medication administration record, document, and communicate the change. So again, we went from 100 milligrams per milliliter, give 7.5 mils BID, to 750 milligrams via G-tube twice daily with food for seizure control. Narcotic counts must be completed at the beginning and the end of every shift when our accurate nurses have access to controlled substances. So hopefully you have someone to complete the narcotic record count with at shift change, but if you have to do it by yourself, that's okay too. So there's room here to write the date, the time, any doses that were given, the route of the dose, your signature, and how much of the medication is remaining. You need to complete an incident report for any discrepancies, which includes an immediate call to the clinical manager or the on-call nurse. The next section in the patient chart is supportive cares and tasks. There will be a document in the chart regarding cleaning home medical equipment with some common guidelines. If there are any different recommendations from your patient's DME provider, follow those recommendations and the cleaning schedule established in your patient's home. The next document is the care record. This is a patient-specific document that reviews the cares required during your shift. So this may include things like hygiene, trach changes, trach site cares, trach ties as you see here, also G-tubes, feeding, oral cares, patient cares that are patient-specific. If there's anything on the care record that doesn't apply to your patient, just skip it. But this is a document that you should review every shift. This document is for 1 month at a time, and you'll start a new one on the 1st of the next month. The maintenance record is a record of cares and tasks that have to be completed on your patient's equipment. So some of the examples you see here are changing the feeding bag, washing and rinsing feeding extensions after use. You may also see ventilator tubing changes or filter cleaning, things like that. You're also responsible to provide patient care plan updates. This will be scheduled in your patient's home to be done on a certain day of the week. It may be on a shift that you're working, or it may not. But there are 3 ways that you can complete care plan updates if this responsibility rests on you. Nurses should call with weekly or bi-weekly updates of the patient. This is not for emergencies. Updates are going to be transcribed and sent to the clinical manager of the patient. So you can call this 800 or 877 number listed at the top. It's not a line that a live person will answer, but rather it's an answering service with prompts where you will leave the message with your patient's update. You can also email to customerservice@accuratehomecare.com. Ensure that you do not use full patient names in your email. That would be a HIPAA violation. Rather, initials are sufficient. We can take a look at the schedule and see where you work and find out which patient you're discussing. Or you can utilize the website. So you go to accuratehomecare.com, click on the Employees tab, and then click on the Care Plan Update form under the Employee menu. Fill in all the appropriate sections, including your name, your phone number, your patient's first name and last name, and your updates for the patient. There'll be a security section at the bottom, and then you can click Submit. The next section is the Other section. So we won't review most of these documents, but clean your hands and cover your cough. Those reminders are in the chart, but patients can also remove those and post them in the home if they'd like to. Incident reporting is a critical element of your role in the home. You must report to clinical manager within 24 hours of any incident by calling Accurate Home Care and completing a written incident report. So according to Accurate Home Care policy, an incident report must be completed when anything out of the ordinary occurs during your shift. Some examples include, but we're not limited to, infections, injury or potential injury to the employee or to the patient, medication errors, drug interactions, narcotic discrepancies, any unlawful situation, home safety concerns, unscheduled or emergency trach changes, G-tube or J-tube, utilizing the emergency airway clearance protocol. Anytime you're calling 911, obviously completing CPR, or if the patient decannulates. Abuse, neglect, or any maltreatment, so vulnerable adult and CPS reports must be completed in conjunction with an incident report, and any other event that poses a risk for patient injury. Sexual harassment, breaches of confidentiality, so HIPAA or protected health information being released. Fraud, waste, or abuse, or a mental health crisis. A lot of different examples here of when to complete an incident report, and again, there are more. So on the incident report, you need to fill in all the blanks. So there's a long list here of those particular elements that need to be included. However, if you complete each section of the incident report, you'll have all of this information included. If a VA or CPS report was made, document the report ID and whether the report was made via phone or through the website. If it was made online, print and submit a copy of that report to compliance and the director of the service line. We will handle that piece of it once it comes into the office. Your important component is to complete the report, call your clinical manager, and send it in. Make sure this includes an objective description of the incident, so not subjective. Don't include your opinions, but include facts. State what happened. Sign the report as the individual completing the report. So this is an example of the incident report, and again, if you're filling out all of these components, then you'll be answering all the questions you need to. So date and time of the incident, when did you report it to Accurate Home Care and what time, who is the person that you reported it to, and was this by voicemail, yes or no? What's the patient's name and age, the location of the incident, and who is reporting it? So then check the box in terms of what resulted, what occurred, and anything that requires immediate notification. And then on the next page, the persons involved. So indicate who is the patient and who is the employee. So you might write something like Tracy, patient, and Nancy, employee. Describe the incident in detail, again using objective language. Also include the patient's condition as a result of this incident. So if you're reporting that you accidentally scraped the patient's arm with a transfer belt and you placed a bandage on, and the patient is probably fine. So ensure that that documentation includes the conclusion, and then send it in to the office right away. This is a separate document. It doesn't stay in the home. There's no carbon copy. You would use one of those self-addressed stamped envelopes and mail it to the office. So let's practice documentation, or think through the practice of our documentation. So in this scenario, you arrive to your shift and receive report from the overnight nurse. The patient is in stable condition, asleep in her crib. You proceed with safety checks and verification of all equipment settings. You open the chart to see that the patient received an order for a new medication since your last shift, and you verify it's been added to the MAR. You notice the patient is waking for the day, so you take her out of her crib to do morning cares. As you take her out, you notice her trach ties are a little loose. While reaching to secure the ties, she sneezes and decannulates herself. You quickly retrieve a new trach tube from the emergency airway kit at the bedside and insert it into the stoma. Patient is crying, dusky, and has copious secretions, so you suction and bag her with 100% oxygen for a few moments until her vital signs are stabilized. Upon a completion of a respiratory assessment, you determine that her lung sounds are clear and she seems to be completely recovered from the incident. So what should you do next? Well, that was an unscheduled trach change, so I definitely want to call my clinical manager, and I should update the physician as well and complete documentation. What's the documentation going to include? Probably a nursing note and certainly an incident report. So if we think about what those might look like, my nursing note might look something like this, including the date and the time. I arrived to the shift, received report from the night nurse, and assumed care of a stable patient asleep in crib. All equipment and safety checks are complete. Upon waking, patient was removed from the crib to provide morning cares. Patient sneezed and decannulated. Placed new trach tube from bedside emergency supply. Bagged patient with 100% O2 as patient was dusky and crying with copious white, frothy secretions. Deep suction effective. Patient calmed within 1 to 2 minutes. Assessment at 0745 was within normal limits. The O2 saturation 98% on room air, pulse 120, respirations 29. The physician was notified of the incident and there are no new orders. Also note that an error was made in this documentation, and demonstrating here the single line drawn through the error with the error written and the initials of the writer. An incident report then will need to be completed as well. So all sections of this incident report here are addressed, including notification of the CM. Did not leave a voicemail, so that means I spoke directly with the CM. It happened in the patient's bedroom, and I'm reporting it as Nancy Nurse, the LPN. This resulted in a notification of the physician, and the following occurred not on this page, but let's take a look at the next page. Decannulation is listed here. The persons involved, Tracy was the patient, and Nancy was the nurse. So describing the incident in detail using objective language, upon waking, the nurse removed the patient from the crib and placed on floor to provide morning cares. At that time, patient sneezed and trach tube came out of stoma. Nurse placed new trach tube from bedside emergency supply without complication. Assisted patient with ambu bag and 100% oxygen for 1 to 2 minutes as patient was dusky and crying. Deep suction effectively cleared secretions. Patient calmed quickly and vital signs stabilized. See vital record. Lung sounds clear in all lobes. MD notified. No new orders or follow-up required. Another item in the home is a communication book. This is really just a spiral-bound notebook, but it's important. It's used to communicate important health information between employees and other caregivers in the home. The communication book should be used for information about medical appointments, new procedures, changes to the plan of care, sometimes as little as our trash days are on Tuesdays now instead of Wednesdays, or for this week, could you please park in the driveway instead of parking in the street? It should not be used in a negative or disrespectful manner. If there's any reports of unprofessional conduct through the communication book, those reports will be taken seriously and we'll follow up with the employees responsible for that. The communication book is not part of the patient's record. So again, this is for notes from staff to staff or from the family to the staff. There are times when the family may place a note in the communication book as well. So what should your shift change look like? One of the questions that we get, especially for people who are new to home care, is, what do I do when I get there? So one thing that you'll review during the meet and greet process is, how would you like me to enter your home? Do you want me to knock or ring the doorbell or just walk in? That varies depending upon which patient you're working with. When you walk in the door, shoes off, house shoes on. Remember, you cannot work barefoot or without proper footwear. We want to be respectful to our patients, so no matter what they say, you shouldn't be wearing your shoes from the street in the home. Next, wash your hands. We've talked about infection control and how important that is. Next, you'll receive a brief report. Report should take less than 5 minutes because we want to minimize the intrusion in our patient's home. Focus on what's new since the last time you worked with a patient. So you might say something like, I worked last week. What's new since then? Or I was just here yesterday, so is there any changes overnight? That will help keep your report brief and focused on the patient. Save any personal conversations for outside of work time. Complete a visual assessment of the patient. Take a look. Do they look okay? If their patient is stable, then proceed to your safety checks, because you know the patient's okay right now, but what if their condition changed rapidly? You'd want to make sure you have all of your necessary emergency equipment. That includes verifying equipment settings, checking ventilators, and looking for all of your backup supplies. Then you'll review the chart for new orders and cross-check with the medication administration record to ensure that you haven't missed any medications, even ones that weren't passed on during shift report. Narcotic counts should be completed face-to-face with the person whom you're taking over cares. So if there is a discrepancy, it can be resolved immediately. Often when there is a discrepancy, we get a call as clinical managers with a person saying, there's a discrepancy, this person wrote down that there were 6 tablets, I'm only seeing 5. And if you would have had the person face-to-face, you could have just asked and resolved the issue right away. Maybe there was one that was dropped, maybe one wasn't documented appropriately. So it's important to do those narcotic counts face-to-face whenever possible. Regardless, they need to be completed at the beginning and the end of your shift. Finally, you'll complete your head-to-toe patient assessment and appropriate documentation, and then proceed with your shift. Thank you for all of your hard work and your efforts. This documentation module is long, however, it's important. And you'll also have a chance during Skills Day to review a sample patient binder as we discussed earlier. So please take a moment to do that. It'll all come together once you see it in your patient's home during your orientation process. Thank you.